Hello and welcome everybody to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association. And today on ICMDA webinars, we've got my immediate predecessor at ICMDA and old friend Dr. Vinod Shah talking on healthcare mission in India, trends, challenges and opportunities. So in addressing problems, we often take a forward approach, assessing strengths and weaknesses, a SWOT and so on, before moving on to strategic planning. But in this session, Vinod is adopting a different method, working backward from the desired impact. He's identified 10 interconnected health-related impact categories that could transform India's healthcare landscape. The audience can then, with them, think about exploring how they can contribute to one or more of these areas. And no specific model is prescribed, whether it's a mission hospital clinic or private-public partnership. The focus is simply on making a meaningful and positive impact on at least one or two proposed factors. And since these factors are all interconnected, it will have a domino effect on the others. Although tailored for the Indian context, this reverse engineering approach can be applied globally and fosters innovation. So Vinod Shah will need no introduction, but to those of you who are not familiar with him, after coming to the Christian faith from a Jain background, Dr. Shah's passion is serving God through healthcare mission. He did his MBBS, MS and MCH from Christian Medical College for Law in Tamil Nadu in India, and he then served as executive director of the Emmanuel Hospital Association in New Delhi. He was head of distance education at CMC Vellore, Christian Medical College Vellore, and from 2014 to 19 was the CEO of ICMDA. Vinod's married to Dr. Shalina Shah, and they're blessed with 3 children. 2 of them are working in North America and 1 in China. So, Vinod, it's a delight to have you back on the program. We can't see you at the moment, so I think if you can switch your video on, and there you are. Welcome. It's great to have you here. And we'll hand over to you now to speak to us on this subject of healthcare mission in India, and then look forward to engaging you in conversation afterwards. Thank you very much, brother.
Yeah, thank you, Peter, and good evening, everybody. That's the topic that was advertised. I'm hoping to initially talk about the trends and why they should be managed proactively. And then I'm going to tell you about 10 big challenges facing the country. There may be other people who think differently, but that's okay. But most importantly, I'm providing an approach to managing the challenges, which is an impact-based approach to taking on the challenges rather than a strategic planning, and also a collaborative approach. Okay, so we are on to the trends. Lifespan will increase from 70 to 74 is one trend, and the other is there will be the Clinical Regulation Act. That means hospitals will be required to set up some basic minimum norms. That is not a bad thing. But the problem is it includes HR, which makes it very difficult for mission hospitals to manage. For example, when you're doing a C-section, according to the Clinical Regulation Act, you need a OB/GYN, and then you need an anesthetist, and then you need a pediatrician to manage the baby that is delivered. Now, none of the mission hospitals will have all of those three people. They may have one or two, but very rarely all three present. That means the biggest service that is being provided by the mission hospitals is OBGYN. And if that is not happening, that will close down many of the mission hospitals. But what will actually thrive is the single doctor clinics, because they will have very little regulation, or they have very little regulation. And so single doctor clinics and family medicine clinics can become popular. And so that is an opportunity. Other trend is the number of medical schools have increased from 300 to 500 to presently 700, and another 300 are under construction. So we will have 1,000 by 2029. The WHO requirement is 1 in 1,000. Currently, India has 1 in 850, and by 2029, it will be 1 in 600. Now, that is a ratio that is presently available in all the European countries. And in some states in India, for example, in Tamil Nadu, it is already 1 in 300. That means it is even better than the Scandinavian countries. So there will be a glut of doctors, which means that they think that the quantity will increase, but the quality of training will decrease because they have increased the number of seats. And there will be a trickle-down effect of doctors into rural areas. They will be compelled to go into rural areas. Now, that can be a good thing. And more doctors may be employed by the public health system in the government. And more doctors will also mean that they will begin to do other things. They will begin a medical tourism company. Already there are some, and those companies will increase, and patients will come from African countries, Central Asian countries to India for medical treatment. And because of the low cost, and because of the fact that India does tertiary care better than primary care, this industry will increase. Because of the glut of doctors, unethical practice will increase, because they will begin to refer a lot to give everybody an opportunity for employment. External migration of Indian doctors will also increase. And that gives an opportunity for Christian doctors to do medical mission work and to be more available to do mission outside the country. And more doctors will specialize laterally. They will not do mainstream medicine, but they will begin to specialize in medical technology. They'll become consultants in medical technology, medical business, in pharma industries, in device manufacturing, and so on. Maybe that is an opportunity for Christian doctors too, because we need Christian people in these businesses and device manufacturing businesses. And then the Indian diaspora is the highest in the world, even more than the Chinese. The Chinese diaspora is the highest in the world, but in the Indian medical health diaspora, India has more numbers than the Chinese. And just in the US alone, there are 100,000 Indian doctors. And they are beginning to invest in India in the corporate hospital sector, in the biotech sector, and some in the charity sector. And then the other trends, there will be, as in other countries in the world, increase in mental illness fueled by individualism, social media, pornography, sexual revolution, and hedonism. And it's supposed to increase worldwide from 10 to 20%, and it probably happened also in India. However, in India, the increase in women and child trafficking and organ trade will increase greatly, because India is the trafficking capital for both women and children. And so a lot of this is also linked with organ trafficking. And so that'll be a huge issue that the Indian authorities may have to manage. And there will be non-inclusive development. India is growing, but India is growing, it's called a jobless growth. That means very high-tech industries that use a lot of technology, but don't use up a lot of people. And so they believe that there is going to be a huge increase there will be a jobless growth in technology, which means that the GDP will increase greatly, but per capita GDP will not increase. That means it will not eradicate poverty and increase disparity. AI and data informatics will become a postgraduate course after MBBS. Climate change and environmental health also will become an important specialty. And AI-driven diagnostic algorithms will begin to slowly replace doctors' critical diagnostic abilities, and surgical robots are slowly coming into even the government hospitals. Just 50 kilometers from here, there is a medical college with robots. And in a radius of about 100 kilometers from where I am, there will be about 6 to 7 institutions with lots of robots. So robotic surgery is coming into India in a big way. This means that there will be a lot of impersonal, the doctor-patient relationship will become more impersonal. And then we also want to look at church growth, because we want to think about Christian trends too in health. So church is growing, luckily, in a big way in these 3 states. We have only indirect evidence of the fact that many people are being imprisoned. And the reason they are being imprisoned, we begin to know, is because they have established churches of 10,000 people and 20,000 people and so on. The church is also involved. The young people in the churches are all in the Pentecostal and the evangelical movements. And they are involved into a lot of social uplift. And they are also involved in a lot of digital evangelism. These are some of the trends that will sustain disparities: increase in privatization, unbridled privatization currently, geographical disparities, jobless growth, technology-driven usually increases the cost of healthcare. Technology can drive costs down, or it can drive costs upwards. But preferentially, the way it works is that usually increase in costs are favored by people in power. And so that kind of technology which increases profits will increase. Environment is worsening, so environment-related challenges will decrease, specifically asthma. Lack of awareness about health insurance means that most people will not be able to access health insurance, and worsening social determinants due to social unrest and joblessness. Okay, another trend that is a problem is the fact that all the sectors, the government sector, the private sector, and the charity sector, they're all working in silos. They are not, there is no structural connection with each other. And so even in the charity sector, the Protestant sector, the Catholic sector, and the other NGOs, they all don't particularly talk to each other. And so that is a problem. Christian doctors are also working in corporate hospitals. Christian doctors are there in the mission hospitals. They are there in the medical schools. They are there in the private clinics, and they are there in the government sector. But they are not particularly talking to each other, even though CMAI and AMFI bring them together. One of the problems is that the doctors in the mission sector have a high moral ground, and so others feel frightened to come together in these bodies. The government sector, there is a public health system and there is a curative system. And these two systems don't actually talk to each other too much. So there is a division not only between the sectors, but even within the sector, there are silos. So if you allow the trends to continue, what will happen is it will lead to more chaos. I'm just using a metaphor. The second law of thermodynamics, it states that in a closed system, energy system, if you don't interfere with it, the chaos within the system will increase, keep on increasing with time. So also, if you don't manage the trends, what will happen is there will be chaos in the health sector in the country. And chaos always means that the rich and the powerful will become more rich and more powerful, and the people who are marginalized will become more poor. And so it is very important that Christians speak into the chaos and that they somehow manage the trends. And so I'm suggesting an approach to manage the trends. I'm calling this an impact-oriented approach, which is actually a reverse engineering. That means normally when you do strategic planning, you do SWOT, strengths, weaknesses, opportunities, and threats. But if you use this process, what happens is you tend to stay within your comfort zone, within your strengths and weaknesses. You don't feel like taking on challenges that are outside your comfort zone. And when you don't work outside your comfort zone, you often cannot make an impact because you're used to working in a particular, with a limited arena. And so I'm suggesting that we do reverse engineering. I'm having difficulty with, yeah. What I'm suggesting is that we create a collaboration, intersectorial collaboration. That means Christian health sector, the private and the corporate health sector, the government health sector, and the other faith-based NGOs and the non-faith-based NGOs, all of them come together to form a collaboration. Now, this is probably asking too much. It requires a lot of leadership. It may not happen on a national level, But it can happen on a state level. I'm saying this because we did this in EHA and we were successful. And so I believe it can be done. And there must be intra-sectorial collaboration. That means the Christian sector also has to come together. The Christians in the mission hospitals, Christians in the private sector, in the Catholic institutions, in the medical schools, and in the churches, they all also need to come together. And now, let me tell you why I think this is possible. After the HIV/AIDS epidemic happened, most severe, affected the northeast part of the country in a big way. You know, the 5 big states in the northeast part of the country. And so EHA, we had made an application to Bill Gates Foundation, and they gave us, I can't quite remember, but it was like $6, $7, $8 million to do something in a collaborative way. And so we recruited people from the 5 states. We recruited private NGOs, we recruited hospitals, the Christian sector, also the government sector through the NACO, that means National AIDS Coordinating Organization. And we began to have conversations with them, and several important areas for impact were identified, and an action plan was made, and training was delivered. There was frequent dialogues and meetings on a regular basis, and we achieved a reasonable kind of impact. And the Bill Gates Foundation was quite impressed, and they offered to give us more money for tuberculosis later on. And so we believe that such a thing can happen, but it requires leadership. Now, if there is one thing Christians have, Christians don't have much money, but they certainly have leadership. And they have leadership because they are highly motivated. And we are highly motivated because we want the kingdom of God to be established in our countries. And so with this leadership ability, one thing we can do is work towards a collaborative council, maybe in a limited area, maybe in a district, maybe in a state, or any other geographical area, and do something in that particular area. And what should we do? We should keep in mind, we should highlight 10 impact areas, like I have done. You may, now this is an example of how there can be a butterfly effect. Now you might think, what can I do? I'm just a small guy, nobody knows me, I'm unimportant. If you think that, you're just the right person for God to use, because there was a Florence Nightingale, was a wealthy lady, but she was not really well known. And she went to, I don't remember exactly where she went in Ukraine, but during the Crimean War, all she did was very insignificant things like cleaning the ward, improving ventilation, establishing hygiene protocols, and she was able to drastically reduce mortality rates from 42% to 2%. And so what happened was she showed what can be done, and then this became a tsunami. You know, nursing schools and colleges started all over the country and then all over the world. And you can see what effect she has had. So also, if you do something in a small district on a collaborative level and show that it works, that will then make a huge impact in the rest of the country. Now, the 10 realities that should be addressed in India. One is the great divide, the inequity. One, two is out-of-pocket expenses. I will explain what I mean. Unregulated privatization. That means not public system, but a private system where you have to pay. HR maldistribution of doctors and nurses and healthcare workers. Appropriate technology to reduce costs. Neglected social determinants of health. Not really health, but other factors that affect health, like education and income, the two most important ones. And then the low insurance coverage, which needs more awareness. Unethical practices. Unethical practices in India cost some millions and millions of dollars. Lack of focus on family medicine and primary care, and emergence of non-communicable diseases, diabetes, hypertension, cardiac, and mental illness. So these are the 10 realities, 10 challenges that should be addressed in India. I'm not going to spend too much time with all these things. No housing, no drinking water, 15% of the schools are non-functional. You can see children not going to schools but doing labor. Infant mortality rate is more in the scheduled caste and scheduled tribe rather than the other areas. Under 5 mortalities also is higher among the scheduled caste and the scheduled tribe, which are the poor people in the country. Again, the division between the rich and the poor. There is a book, I talked about this in Tanzania. This provides evidence that this inequality or iniquity affects not only the poor, but it affects the well-to-do. The well-to-do will be affected in a different way. For example, they may be affected by violence, and they might be affected by mental illness. Inequity will produce more teenage pregnancies. This is in the US, but they will have psychological effects on children in every country in the world. And these are other books that have hardcore evidence that inequity is dangerous for any country. These are the areas where the well-to-do will also be affected. Mental health, drug abuse. The well-to-do will have children who will have the money to do education, but they will drop out. The well-to-do children may go to jail. They may become obese. So all this will affect even the well-to-do. So inequity is bad and needs to be addressed. Again, Lancet has got evidence that inequity is bad for all. And Christians want equity. They don't simply want equality. And you can see the difference between equity and equality. There is scriptural evidence to support equity. Okay, now we go on to the out-of-pocket expenses. Why is out-of-pocket expenses important? Because it drives people below the poverty line. In India, every year, 7% of the population go below the poverty line. And there is inflation. Medical inflation is 14%, but the salaries don't increase 14%. And then 63% of the expenses in India are out-of-pocket expenses. And government is spending only 1.5% of the GDP, while other countries are spending 8% and 10%. US spends 15%, 10 times what India does. The again, 60 million each year go below poverty line in India. Some of them commit suicide. Out-of-pocket expenses in India is 50%. The global average is 18%. This is the breakdown of the out-of-pocket expenses: medicine, hospitalization, diagnosis, and consultation. And borrowing from pawn shops, 24 to 36% of this out-of-pocket expense comes from the pawn shops, and they don't get repaid. And often suicides are a way of paying off debts. What they do is they will transfer the house or something in the name of the wife and the children, and the man who has borrowed will commit suicide. So the debt sort of gets paid. Consequences of excessive privatization. Because the public health system is not functional, because the government is spending only 2% or 1.5% on public health, private parties have taken on, hijacked the health system. So there's a big increase in cost. There is a urban-rural divide because all the private people are in the urban areas, and there is no regulation for the private sector. So there is a lot of unethical practices, and they are not interested in primary care. And so money is in the tertiary care. And so the cycle goes on. Now, there is a dangerous thing that is happening in the corporate hospitals. The corporate hospitals have recruited ASHA workers. There must be like 30, 40,000 ASHA workers in the country who are paid a small amount of money by the government to do primary health care. Now, the ASHA workers get so little money from the government that when the private hospitals provide them incentives for referring, for example, if they refer a patient for surgery to a private hospital, they will get 10% of the operation fees. And so all the ASHA workers, all the quacks, all the general practitioners are all busy referring patients to corporate hospitals, and they get money from the corporate hospitals. And so this was going on. I'm sure most of you know how there is a HR maldistribution. Urban areas more, rural areas so little, and then North India less, South India much more. Specialists again much more in the south of India and less in North India. Specialists almost exclusively in urban areas and very few in the rural areas. Social determinants of health. I will only talk about two of them, and they are education and income generation. Now, it's a good time to tell everyone on this group that health contributes only 20% to the total health of a nation. 80% is contributed by social and economic factors and other non-health factors. And the two most non-health factors are education and income. Now, the more educated you are, the more health you have. The longer you stay in school, the longer you live. And the more money you have, the better your health tends to be. There are other commercial determinants and spiritual determinants. I'd like to talk about just two of them. One is the secularization of school education, family breakdown, and loneliness. loss of church community. So these important spiritual factors are affecting health in a huge way, especially to mental health. Uh, the health coverage, insurance coverage in India is very poor. You can see it is 16% and 12%, and sometimes in single digit. Only 25% of the private sector have become panelists in the insurance sector, because the private sector is saying we cannot manage with the amount of money the insurance companies are giving us. We don't want to be empaneled in the insurance company. So that is another problem. So if you have health insurance, you can go only to some hospitals which may not have all the facilities that may be needed. These are all a list of the unethical practices in health. There's a big list. It's difficult to even go through the list. Family medicine is pro-poor, and that is not really very popular. But Christian Medical College is doing all it can to change this. Non-communicable diseases have increased greatly. They have increased so much that all the doctors put together cannot solve the problem of non-communicable diseases. Doctors cannot help with NCD. Some kind of innovation is needed. The most important innovation, I think, which will help is training of alternative health force. We have to train diabetic technicians or hypertension technicians or something like that to be able to manage the volume of diabetics we have in the country. So this is again just a list of the 10 challenges that I've talked to you about. I've closed my presentation, Peter.
No worries. That was brilliant. Thank you, Vinod. Hugely comprehensive and prophetic in terms of seeing the trends and where they're going forward. And we've got a time now. We've got about a quarter of an hour left for question and answer. So if you've got questions, then please put them in through the Q&A icon at the bottom of your screen, and we'll pick those up. Just a reminder that we've got translation today available in Spanish and Chinese, and you can access that through the interpretation icon, the little globe at the bottom of the screen. So first question, Vinod, Shivam Natarajan is saying, very well balanced presentation. Isn't chaos an opportunity always for Christ-centered work? As you say, asking for collaboration in India, even within the Christian denominations, is a challenge. So the question is chaos the basis and means of greater Christian work? Just thinking aloud like you, he says. So just as I guess the pandemic and the Ukraine war and things created incredible opportunities for creativity and innovation. Is this part of God's plan? So some comments on chaos.
Yes, I think what Christians have to offer is their leadership ability. I have seen that often we don't have silver and gold, but we have leadership ability, and chaos is a time when there is the need for leadership rather than for money. And so it is an opportunity for Christians.
Yeah, thank you. A question of clarification. Shari Falkenheimer, who you know well, is asking, what is the Ayushman related to insurance coverage, which was on one of your slides?
Yeah, it is a government insurance coverage given to people below the poverty line. The government has identified people below the poverty line, and they've given them cards, and so that insurance is supposed to be available to everyone in the country below the poverty line. But there are some problems. One is the amount of payout is capped, means a particular disease, you cannot claim more than this particular amount. And that cap is too small for many of the hospitals. So many of the hospitals are not empaneled. But the bigger problem is that many of the hospitals have faithfully honored the Ayushman cards and treated thousands of these patients, but government has not paid them the money. And so crores of rupees have to be given to some hospitals, but they're not being given. And so the government has not kept its word. And so hospitals now don't want to entertain the Ayushman card because they know that getting back the money from the government will be a big process.
Yeah. Sure, that brings us on to the question of corruption. Mike Soderling, who you know well also from Health for All Nations, is saying, with regard to the unethical practices, it's not possible to list or discuss them all, but he's wondering how important do you think it is to address corruption in the institutions in India, including within the church, and what sort of effect they have on the overall picture? How big a player is corruption?
Yeah. You can address corruption in two ways. One is what I call the internal regulation, and the other is external regulation. You know, external regulation means audits and metrics and compelling them to be transparent and all sorts of rules and regulations the government can have. But then, and using technology to reduce corruption. But then there are always ways of bypassing external regulation. What we also need is the internal regulation. That means a culture that people don't have to become Christians, but the culture so changes that people abhor being corrupt. Now, Finland and Norway, corruption levels are very low, but the people are not Christians.
Yeah.
But so what is it? It is in the culture. Something happened to the culture because of Christianity that existed for many years. Christianity has vanished, but that culture that abhors corruption continues. So we need that culture. We need to create that culture in the country. And that is for the Christian church to do and to speak and to promote that. So there is the external and there is the internal. But we all know that that is not easy because even the Western countries, now the corruption levels are increasing. The Transparency International indices, according to those indices, corruption levels in the US and the UK are also increasing. That means something is going wrong. The culture that Christians promoted, the influence of that culture is decreasing and corruption levels are increasing. So I don't have an easy answer to your question, but external regulation and internal regulation are two possible methods of managing corruption.
Yes, I mean, the example of the Scandinavian countries and some others where there's such a strong Christian legacy, which has an enduring effect even after Christianity's waning. But as you say, eventually, as we're seeing in the US and in the UK in particular, with the rise of post-Christian worldview and atheism, it begins to go eventually. Mike Soling has got another question here about the worldview of Hinduism, and the whole idea that of karma, that reincarnation, that we're getting what we deserve based on a former life and so on. Why does the church, or why does the government in India care at all for the poor? Do you think that's part of a legacy of Christianity as well, or is it? I mean, we can understand why the private sector does, but what about the government? What motivates them?
Yes, I think the government sector is now also consists of people who are, it's called crony capitalism. So the government is now fully with the private sector and managed by the private sector. The private sector is so wealthy that they have the government in their hands. So, but yes, you're right. The legacy, the British started the medical schools in 1830. Uh, Grant and some Christian people started the medical school in Bombay. Um, and the mission hospital is started by Christian people. So that legacy of healing was brought into the country by Christian people. So that legacy kept going for a while, but now it is completely hijacked by the private sector. So
Yeah.
Christianity, healing is not really a vocation. Healing is really a commercial activity. And the leadership has been provided by very big industrialists. And this is why the Christians have failed in providing leadership in the health sector. And one of the things that Christian medical colleges and Christian leaders should do is provide leadership so that we get back the understanding that healing is a vocation. But your question is right. Karma is one reason. The other reason is the body is bad. The soul is good and the body is bad. So in its pure form of Hinduism and Jainism, healing was not really very important because the body was dirty. And unless the body degenerated and released the soul, there was no use. So, people wanted to flagellate themselves and punish their bodies, and looking down on the body was part of the culture, and so healing was not really so very important.
Hmm. Now, you talked a lot, Vinod, about the social determinants of health. I think 20% of disease related to healthcare, 80% social determinants, and you particularly highlighted the importance of education and income. And of course, the link between income and health is well known and documented around the world. But Sukho Lee is saying, given that there's a direct link between income and health, would it not be prudent for Christian communities to adopt a holistic and coordinated approach to health along with income generation by the church, helping people in a sense to become more wealthy in order indirectly to improve their health care?
Yeah, I think that understanding is somewhat recent. By recent, I mean maybe 30, 40 years. The link between education and health was not fully understood uh, by common people, but many Christians understood that. And so many mission hospitals also have a school associated with it. Not all of them, but some of them. So I think some Christians understood, some Christians did not understand, but the full understanding has taken time.
Hmm. Just coming back to technology again, and I mean your comment, especially that technology is much less dependent upon healthcare workers, and so it's not using human input as a resource in much the same way. But I know you've been working in the whole area of innovative devices being used at the community level by trained healthcare workers. And Shivam Natarajan is asking any practical suggestions on how health tech can be a quick and rapid and possibly even a scalable means for Christian medical work, thinking particularly about population screening and telemedicine, which I know you're a great champion of.
Yes, so I think all the big devices should be made retail. That means you should not have a big ultrasound machine in a hospital. You should have handheld ultrasounds that you distribute to all the health workers.
Yeah.
So what that does is the wealth is not concentrated in hospitals with big machines, but you make it available on a retail basis to lots of people who can do work in the community, even in their homes. So it is possible to make all these devices more retail. I think there have been X-ray machines which are portable, are available, and what do you call that? Monitoring equipment, ICUs, even dialysis machines can all be portable. And so the more retail you make it and the more healthcare workers you train, the more people will benefit. But if it is concentrated in huge hospitals, then the profits will go to some people and the rest of the people will get very little. They will get no jobs, and the money that others make will be much smaller than the owners of the hospitals.
Yeah. Thank you. You raise the importance of collaboration as well, not just within Christian communities and the silos in which Christian healthcare workers are working, but also at local community, state level. And Timothy Hardcastle is just highlighting one resource there on collaboration, the Christian Health Asset Mapping Consortium, which is being led by Christian Connections and International Health, CCIH, and in which ICMDA has been involved as well, contributing. And then just a question from a student here, and you highlighted, Vinod, the importance of leadership and the fact that that's one of the real contributions that Christians can bring, because they're highly motivated, they see the kingdom of God, and they want to make a difference. And Bharath Devarapalli is saying, where exactly do you think a student should start exploring his or her leadership abilities? Especially where exactly do they need to exhibit them in the mission sector in India? So what advice could you give to students, junior doctors and dentists who are really wanting to make an impact in the future and wanting to develop their leadership skills?
I think, first of all, you have to keep your motivation levels up. Now, to keep your motivation levels up, you have to keep your relationship with God, very strong, so that you don't lose your motivation. What happens often is people are very motivated when they are in medical school, and when they graduate, they lose it all. And so one thing is to keep up your motivation levels by keeping up your relationship with God very active. Secondly, keep the big picture in mind always. Yes, work locally, do your small work well, but don't forget the big picture. So always connect what you're doing to the big picture all the time. So if you do that, I think you will become a leader. And also don't allow people to put you down. Don't allow people to say you can't do it, because you can.
Thank you. It's a great note to end on there. And just right at the beginning, of course, you emphasize how important it is that we don't apply an antiquated SWOT model, which only really works when you have the power and control to see it through, but rather see the importance of the butterfly effect. Beautiful picture of Florence Nightingale in Ukraine, who was just doing small things, small significant things in a small corner, and made such an incredible impact. And of course, the knock-on effect, as you say, just like the dominoes. So I think it's an encouragement to everybody, wherever they are, that you really can make a difference, and that you should do everything you can and work with others and collaborate. So thanks, Vinod, for the big picture, for inspiring us, for your own example, and just a reminder that today's session has been recorded and it will be available from the website. And just thank you again. Thank you, Vinod, for your wisdom, and for all of you for coming and joining us today on ICMDA webinars. May the Lord bless you.